Our next speaker will be Dr. Esdahl from Gunderson Health System in La Crosse, Wisconsin, presenting on the association of frailty score and surgical site infection after lower extremity revascularization.
So I'm Andy Edsel. I'm a general surgery resident at Gunderson Health System down in La Crosse. And as introduced, our study investigated the association between frailty score and surgical site infection. Surgical site infection remains a persistent challenge for vascular surgeons operating on the lower extremities. Rates of surgical site infections after infrainguinal bypass, for example, ranges from 5 to 32%. And these infections are associated with prolonged hospitalization, excess mortality, and higher costs of care. There are a number of known risk factors for lower extremity surgical site infection, and these include diabetes, smoking, female gender, prosthetic graft use, obesity, and steroid use. And this study sought to evaluate whether or not surgical frailty might also fall into that category. Surgical frailty refers specifically to the state of decreased physiologic reserve that predisposes a specific patient to excess morbidity and mortality from surgery. This concept has been associated with longer hospital stays, increased 30-day readmission rates, and increased perioperative complications. Traditionally, frailty is associated using a proxy figure such as age or ASA classification, or subjectively using the eyeball test, whereby an experienced surgeon can ascribe a preoperative risk profile to a patient. But in recent years, attempts have been made to more objectively quantify this concept of frailty using a number of frailty scores. One such score is the Risk Analysis Index, or RAI. This was developed in 2011, and it uses ACS-NSQIP variables to predict postoperative morbidity and mortality. This RAI was subsequently crosswalked to VQI data to create a vascular-specific frailty index, referred to as the VQI RAI. This frailty index is a composite score comprised of age, gender, BMI, renal disease, heart failure, dyspnea, living status, and functional status. And per previous studies, frailty has been defined in a binary sense as a cutoff of VQI RAI score of greater than or equal to 35. So with this in mind, we sought to retrospectively evaluate the utility of this VQI RAI risk analysis index as a predictor of surgical site infection among vascular surgery patients undergoing open lower extremity procedures. This was a retrospective review of all patients undergoing an open lower extremity procedure from 2007 through 2019, excluding percutaneous procedures. Our primary outcome was surgical site infection, and our secondary outcomes were unplanned return to the OR with surgical site infection and death within 30 days. For each surgery, preoperative frailty was evaluated using the VQI RAI frailty score. Wilcoxon-Rank sum tests were used to compare frailty between patients who developed a surgical site infection and those who did not, while chi-square and Fisher's exact tests were used to compare surgical site infection outcomes between those defined in the binary sense as frail or not frail. 1,506 open lower extremity procedures were performed during the study period. Of these, 376 were excluded due to incomplete data, leaving us with 1,130 procedures included in the analysis. Our study demographics are here. The median age of our patients in this study was 72 years old, and 72.6% of patients were male. You can see here the frailty distribution of the patients in the study, again highlighting that previously reported figure of greater than or equal to 35 as a cutoff for frailty, which captured 14% of the patients in this study. The procedures performed during the study period are listed here in order of decreasing frequency. The most common procedures performed fell under this classification of hybrid procedures. So these are open exposures for delivery of an endovascular stent, be that aortic, femoral, popliteal, or iliac. Following that, we had femoral endarterectomies, lower extremity bypasses using vein or non-vein graft, and finally lower extremity embolectomies. For our primary outcome, we found that 8.05% of patients experienced a surgical site infection. Of these, the vast majority were superficial surgical site infections, although a number of deep incisional and organ space surgical site infections were also noted. For our secondary outcomes, we found that 4.69% of patients died within 30 days of their procedure, and 3.19% experienced an unplanned return to the OR with surgical site infection. Looking at frailty defined in the binary sense, that is a VQI RAI score of greater than or equal to 35, we did not find an association between frailty and surgical site infection incidence that was statistically significant, with a p-value of 0.31 calculated for this. We then looked at frailty as a continuous variable along this continuum of VQI RAI scores. Here too, we did not find a statistically significant association between frailty and surgical site infection, with a p-value of 0.4 and an ROC area under the curve of just 0.52, indicating this association between frailty and surgical site infection is a little better than a coin toss. We then sought to deconstruct this frailty index and look at the individual components to see if any of those were statistically significantly associated with surgical site infection. And of these, only BMI had such an association, with a p-value of 0.0001 calculated. The remainder of the elements of the frailty index, age, gender, pre-op creatinine, dialysis status, dyspnea, CHF, pre-op functional status, and transfer status, were not significantly associated with surgical site infection. For our secondary outcomes, we looked at unplanned return to the OR with surgical site infection. Here too, we did not find a statistically significant association between frailty and surgical site infection. And while the association was not significant, it is worth noting that in our sample size, the patients who returned to the OR with surgical site infection actually had lower frailty scores than those who did not. Our final secondary outcome, death within 30 days, was also, this here was statistically significantly associated with surgical site infection. P-value of 0.03 was calculated, and the ROC area under the curve was 0.59. So, in summary, we did not find an association between frailty, as measured by this index, and surgical site infections. We also did not find an association between frailty and unplanned return to the OR with surgical site infection. We did find an association between 30-day post-op mortality and frailty, and among the individual components of the VQI-RAI vascular-specific frailty index, only BMI was associated with surgical site infection risk. The limitations of this study largely relate to its nature as a single-site retrospective study. Looking at our results in the context of the literature surrounding frailty, and this index in particular, our data are somewhat inconsistent. There has been one study which showed statistical significance in an association between VQI-RAI frailty and surgical site infection, but this looked only at lower extremity bypass and didn't look at the large number of hybrid procedures that were included in our study. Our 30-day mortality association data is consistent with published data, which shows a strong association between frailty and 30-day mortality, not only in vascular surgery, but across a whole range of surgical subspecialties. One possible takeaway from this study is that this VQI-RAI index is a simple but fairly comprehensive tool, and its weakness at predicting surgical site infection does not bode well for other indices. And rather than looking for different frailty indices to explain this association or lack thereof, it might be more prudent to evaluate the specific underlying pathophysiology of surgical site infection, including things such as BMI, when looking to predict surgical site infections for open lower extremity procedures. Thank you.
Paper is open for discussion.
Although slightly tangential to the exact nature of the frailty index in your paper, did you see any changes in these risk factors or the SSI rates over time as the advent of other negative pressure therapies and things have been used more presumably in your practice?
Yeah, interestingly, we did not. I mean, obviously there was variation year over year, but the overall trend over the 12-year study period was not one of decreasing rates. And you could actually look at specific points in which different preoperative protocols were controlled for, specifically using cefoxitin, a pre-op scrub, and the negative pressure dressings as you described. And at none of these points was a significant difference in rates observed.
Dr. Matos?
Hi, Mark Matos from Flint, Michigan. Very nice talk. I think it's important to assess the frailty. The question I had to remind me, what was the BMI cutoff? Was it
so there was no specific BMI cutoff here. In the score, it's a BMI of greater than 28 or less than 16. So there's two cutoffs, I suppose.
Okay, because I'm 30. And I'm trying to decide if I'm obese or not. So the other question I had is, I'm grateful that we can't tell, but the question I had for you is, did time with an open groin make a difference? Did you look at that? And whether or not it was a redo? Because if it's a redo groin, I'm thinking that's frail. And for us, if we leave our groins open more than 4 hours on any complex case, we think in our hands we have an increased risk for infection, just like your thoughts. Very nice talk.
Thank you. And yeah, I think that's an extremely salient point. I think there's a number of things you could look at in terms of the actual procedures performed, be it indication or redo groins, and you almost certainly would find that association. Whether or not that association would be attenuated or enhanced by preoperative frailty is an interesting question and worth looking at.
Oh, thank you. I enjoyed your presentation. One other question for you. Did you look to see how the patients presented in terms of Wi-Fi score, or whether they were rest pain or tissue loss in terms of impacting your surgical site infection, or whether they were related to frailty? Were more frail patients presenting with worsening Wi-Fi scores?
Sure. Yeah, we didn't hear, and part of that was the fact that not all these procedures were in fact performed for lower extremity ischemia. There were a substantial number of aortic endovascular repairs included in here with cut downs, but I think, again, a very salient point.
Thank you. So we'll move to the third presentation.